Hi, everybody. My name's Rob Ward. I am the senior author for this paper that was recently accepted in AJR, Cryoablation of Primary Breast Cancer in Patients Ineligible for Clinical Trials, a Multi-Institutional Study. And I'm excited to tell you a little bit about the study. Before we talk about the actual paper, I want to take a few moments just to recognize the people that were involved in putting this study together. First, by pointing out Dr. Karim Weedat, our first author. He was a research assistant at Brown while we were preparing this paper and actually just started his radiology residency program at Tufts. Additionally, you'll see Dr. Grayson Baird, our biostats guru. Unfortunately, we can't find a picture of him anywhere on the internet, so that'll have to suffice for now. Dr. Camelia Kozlowski and Dr. Belinda Barclay-White are two breast imaging radiologists in private practice who happen to do quite a bit of breast cryoablation and have been doing this for quite some time. In fact, it was Dr. Barclay-White that called me several years ago and said, hey, look, we really need to publish results of patients that we've treated in clinical practice outside of a clinical trial. So hats off for the suggestion, and finally, here we are today. Next, I want to call out Drs. Michael Plaza and Kenneth Tomkovich. Back in 2016, when I started doing cryoablation, I actually flew down to see Dr. Plaza in Miami and watch him do a couple of cryo cases of fibroadenomas. So that was a really invaluable experience to me. And we're also very lucky to have Dr. Tomkovich on board as a co-author because he's actually one of the ICE3 trial investigators. Drs. Peter Littrup and Hussein Ayoun were colleagues at one point back in the day. And I actually know Dr. Littrup really quite well because he was also faculty at Brown while I was in training. So he's been an incredible mentor to me over the years. And he's probably done more breast cancer cryo cases than anybody out there, particularly those that are done off trial. Finally, I want to thank Dr. Nicholas Pigg, who is one of our breast imaging fellows at Brown and has done quite a bit of breast cryo work in a short period of time. Before moving on to the actual paper, I want to specifically thank Dr. Andrew Rosenkrantz, the editor-in-chief at AJR, as well as Dr. Wei Yang, the breast imaging section editor at AJR, as well as all the reviewers that saw our paper. Their time and effort really contributed in a significantly positive way to strengthening our paper into what the final product is today. So thank you. Breast cancer cryoablation clinical trials have strict inclusion criteria that exclude patients with potentially treatable disease. So the objective of our study was to evaluate the safety and outcomes of breast cancer cryoablation without surgical excision in patients ineligible for prospective cryoablation clinical trials due to unfavorable patient or tumor characteristics. So cryoablation is really looking to devitalize tissue with extremely cold temperatures. And here are a couple of images from a cryo procedure. On the left, a biopsy-proven cancer. In the middle, that cancer with a single cryoablation needle through the center of the lesion and a little bit beyond. And then on the right, the mature ice ball formed, causing the anechoic shadowing. Cryoablation has benefits over surgery and potentially other ablative modalities because it requires only local anesthesia, and we can use ultrasound to guide needle placement and also monitor the ice ball in real time. So prospective clinical trials are looking to enroll the ideal candidate, and these are really the screen-detected breast cancers that we see so commonly. They're unifocal, they're invasive ductal carcinomas, less than 25% intraductal component. They're hormone receptor positive and HER2 negative, well visualized on ultrasound, less than or equal to 1.5 centimeters on all imaging modalities, and ideally greater than 5 millimeters from the skin, greater than 3 millimeters from the pectoralis muscle, and clinically node negative as well. So in our study, we were looking at patients that had some unfavorable characteristic, whether they were too big, the wrong histology, not very well seen, too close to the skin, etc. So in reviewing the methods, this was a retrospective study, and cryoablation of biopsy-proven unifocal breast cancers was performed with locally curative intent, no surgical excision, in patients that were ineligible for cryoablation clinical trials. And we had 7 total institutions contributing data on procedures performed between 2000 and 2021. The procedure was considered technically successful if it achieved intended treatment parameters and was not terminated prematurely for any reason. In addition to having the first imaging follow-up showing no evidence of residual disease, if both of those were met, it was considered technically successful. Additionally, it's important to note that biopsy was only performed for suspicious imaging findings that occurred during imaging follow-up, and we recorded ipsilateral breast tumor recurrence and categorized those into either true recurrence or new primary. True recurrence being at the site of ablation, and new primary being at a distant site and distinct from the original targeted lesion. In the end, we had a total of 112 patients that met our inclusion criteria for this study. The median age was 71 years of age. And of those 112 patients, 7 had minor adverse events that did not require any sort of treatment. There were no moderate or major adverse events. And the procedure was considered technically successful in 98% of those cases. So there were only 2 treatment failures on technical grounds. So now we have 110 patients that had technically successful procedure. 20% of them ended up having biopsy for suspicious imaging finding that occurred in the ipsilateral breast. A little under half were benign concordant findings at the time of biopsy, and a little over half ended up being ipsilateral breast tumor recurrence. So that ends up being about a 10% ipsilateral breast tumor recurrence rate in the patients that were included in this study, 7 of which being true recurrence and 5 being new primary disease, and only a small fraction ended up having any form of adjuvant therapy. So in this study, with a recurrence rate of about 10% over a 2-year imaging follow-up period, being higher than what's been recorded in the prospective clinical trial literature, that's not necessarily surprising because the patients that we studied were not ideal cryo candidates and they were treated off trial protocol for that reason. So we concluded that in select individuals with unfavorable patient or tumor characteristics, breast cancer cryoablation provides a safe alternative to surgery with good outcomes, and that these findings may be particularly relevant in patients who are also poor surgical candidates due to medical comorbidities. And so we also said that breast cancer cryoablation can be safely applied in a larger population than defined by clinical trial inclusion criteria. And with that, I'm going to conclude, and hopefully this got you interested in breast cryoablation. And I'd encourage you to go on the AJR website and download our paper and take a look at it in closer detail. Thanks so much.